Okay, well, I think we're going to get started since it's 10 o'clock and start with roll call here. And so we're going to just first go around in the room here in CTAC and do introductions. Denny, you want to start us off?
Hi, Denny Lorden, Telemedicine Program Coordinator for Providence St. Joseph Health.
Hi, John Scott, UW Telehealth. Nicole, do you want to introduce yourself?
Sure. I'm Nicole Groen. I support the CHISO office, or the Chief Health Assistant office at UW, but I'm supporting you guys today.
So Nicole's pinch hitting for Jamie.
Thank you.
Hi, I'm Sarah Orth with Seattle Children's.
Hi, Brody DeGenko, Columbia Health Solutions Regents.
Great. Let's go to the phone, and I know we have Francis Goff. So Francis, good to see you. And we don't actually see you. I know you have video, but it looks like it might be your ceiling. So, and I'm wondering if we have Cheryl Huchala. Cheryl couldn't join us in person, but she said she was going to call in. Cheryl, are you there? Not yet. Okay. And Joelle? Joelle, let's do a sound check here. I see your mouth moving. Joelle, are you able to hear us? Okay, all right. And Joelle, we're getting a lot of static. I don't know if there's...
I think that was coming from Leslie.
Okay, all right. So Joelle, let us know if you need some help on the audio there. Stephanie? Stephanie, want to say hi?
Hi. Yes, I'm on.
Hi, Stephanie. And do we have Lori Wakashigi?
Yes, I'm here, Dr. Scott. Hi.
Hi. Great. And let's just do a roll call here. I don't think we have Senator Becker or Senator Cleveland. Okay, or Representative Schmick, Representative Riccelli. I think everyone's still in session, so we don't get any more legislators, unfortunately, today. What about Kathleen Damon? Kathleen, do we have you? Or Dr. Cable, Chris Cable? Chad Gavilan? Sheila Grin-Shook? See if we have Cheryl Huchala.
Here.
Dr. Scott, it looks like you're muted in the room. No, you're still muted. You may have to go up to this computer that's running the software and unmute there.
How about that? Does that work?
Okay, I guess we had some volume issues. Can you hear me now?
Yes.
Yep.
Okay, great. We were just taking attendance. So I think we had gotten to Joelle Fathi. I'm going to see if Chris Cable.
Yeah, I'm here, John. Just joined. Thank you.
Okay, great. Thanks, Chris. And I know we have a new person from LNI. It used to be John Bose, and I apologize if I can't remember your name, but if we have the representative from Labor and Industries. No, okay. Dr. Jimenez? Dr. Jones? Dr. Kie? Ryan Kie? Okay. Scott Kennedy, Adam Romney, and we got Lori Wakashigi. Anyone else from the collaborative who wants to introduce themselves? Okay. Well, we can hear you now. Okay, great. Well, good. So I think what we'll do first is just go through the agenda. And let me share my screen here, just to let you know what we're going to be talking about. And the first order of business will be going through the minutes from last time. And then Joelle and Sarah will give us an update on the LMS training. And then there's just a brief announcement about the dialysis centers as an originating site. There will be a hearing in May. Let's give you some details on that. I had a student who was going to work, who's been working with me, and unfortunately that person can't come today, so we're not going to talk about telehealth and physical exam today. We're going to wait for that person to get off service. And then Danny's going to give us an update on the palliative care report. And then I think we're going to spend most of our time really just taking a step back and reviewing our charter and maybe some of the items that have not been addressed in the last two plus years, and see if there's some things we can put on our future agendas, and then we'll have time for public comment. So let's go to the report here. Here we go. Just blow this up so people can see. And so for the folks in the room, you should have a hard copy of that. We talked about the telehealth training. I think there was just some items about abbreviations that hopefully will be changed in a more recent report. Talked about a checklist, and then we're going to add this on slide 34. And then Joelle gave us an update on Washington State Nursing Association and the NCQAC position. And this is a great resource to have that partnership with Washington State Nursing Association. We'll hear more today about that. And we heard from Caratel about the NRTRC conference. And just a reminder that the next Northwest Regional Telehealth Resource Center conference will be in Anchorage, Alaska in the summer, which probably be a great time of year to be up there. This is about a $200 registration, quite a bit cheaper than ATA. For those folks who are interested in attending, ATA tends to be around $700 to $800. And so if you're interested in this but don't want to spend as much money or go to New Orleans, this is a nice resource. And then there were a couple bills that were being proposed, most notably the training, telehealth training. And just to give you an update, I think that did pass out of the Senate. I don't know if it has passed out of the House. Yeah, okay. So stay tuned on that. And then we talked about the Technical Assistance Center. And I think it was decided that at this point in time, we probably would not pursue that, basically because we have the collaborative and our TRC. And then I'll remind folks our next meetings at the end of our meeting today, but just to give you a heads up, the next meeting will be in Vancouver, Washington on Monday, May 6th. So we haven't gone down to the southern part of our state, and Lori Wakashige has been very nice to host us on May 6th. If you can join us, that'd be great. It's in person. And then the other one is June 27th. That will be at Confluence Health in Wenatchee. It's again a place we haven't been to, the kind of the central part of our state. So we're looking forward to that. And then I believe that August 22nd date, we are hoping to have that either in Spokane or in Newport, which is in the Pend Oreille County, northeast part of our state. We'll be probably the most rural we'll get for this collaborative meeting. I have been there personally. It's a beautiful part of our state. If you can, it would be great to have folks join there. But we're still looking to September and November for hosts. So maybe folks in the Puget Sound region, we could bring it back to there. So just see if there's any questions or comments about the minutes from January.
And for those of you on the phone, if you press, I've muted you, but if you press *6, you should unmute and then be able to comment.
And Nicole, are there any comments on the chat that I should be aware of?
None so far.
Okay. So we are monitoring the chat. Okay, well, if there are no edits or comments on it, can I get a motion to approve them?
Motion to approve.
So Danny,
Second.
Chad, second. All those in favor, please say aye or raise your hand.
Aye.
Aye. Okay, anyone opposed? Okay, great, well, we will finalize those and post those to the WISHA website, and those will be up in the next week or so. So then our next agenda item is to talk about the LMS training. And maybe I can ask Sarah to start us off, give us an update, and then Joelle, maybe we'll, after Sarah's spoken, we'll check in with you, especially about the WSNA relationship. Sarah, you want to give us an update?
Sure, thanks. I'm glad we reviewed the minutes because we've done a lot of work to this since then. So we made all the changes to the slide deck that were recommended. Dr. Scott, you reviewed those changes too. I then recorded myself giving kind of a lecture of the slides. It ends up being almost 19 minutes long. And thanks to Joelle for helping to coordinate with all of that and the logistics and the hardware. So it's turned into a video now, and I handed it over to Joelle.
Yeah, Joelle, do you want to give us an update on the next steps from here and when this will be, maybe a timeline of when this will be available to public?
Yeah, great, thanks. Can you hear me on this computer?
Yes, loud and clear.
Okay. So WSNA has the content. There were a number of things that we needed to put together just to make this e-learning module sort of end-to-end appropriate for a learning environment, including a pre and post test. Anyway, they've got all the content, and judging by my conversations with them, I think it'll be up within the month. And I can keep you updated. There was a delay because the director of education there had some requests and it came back to us, but we were able to get it turned around. So we'll keep you all posted.
Okay, great. So in terms of logistics, Joelle, this will be hosted on the WSNA website, is that right?
Yeah, they have a learning management system. So there's actually a website where people can go to take any education at this site. So it would be accessible to anybody that goes there. And Sarah had a great idea that although this will be more of the formal learning platform where they'll have to do a pre and post test to demonstrate knowledge accrued. And then there will be, if this ends up being if this goes through the legislature and becomes mandated, there will be capability to actually direct learners at the end of the module over to the, let's say theoretically, the DOH website to download a form that is their attestation that they completed it. But we can also log how long they were in there, and we can set an 80% pass rate on the test, and kind of really set it up as a formal process. And but Sarah had the great idea that perhaps we should also provide this on the WISHA website, certainly free of charge, not necessarily, it won't necessarily be set up like a formal education module that could, be monitored and reviewed historically if there was any question about whether or not someone had completed the module. But at least it would be available to others. And so she recorded it in a format that it could be easily uploaded if WISHA is able to do that. And I guess it would just be up to the collaborative if that's something that they want to do.
Okay. Joelle, can I just follow up the question? You mentioned it was free, and I was under the impression last time that it was $25.
Yeah, sorry for the confusion. So when you load items on a learning management system and there's a third-party manager of that, there's a cost that comes with each user that comes to the table, each unique user on an annual basis. And that's where the cost comes in for WSNA to manage the education and record it. And, it comes to a cost for them. So in that formal setting, if people come to the LMS and take that education module, then it would be at a cost. The value of that and getting this all set up at the LMS at WSNA is that if this in fact becomes a mandate that people need to go do this education, it'll be ready to go. I assume that the DOH might want to review it and ensure that it's meeting all of the quality marks, but it will be totally set up end-to-end like an educational module, and it'll be more interactive. That versus just uploading the video that anybody could go watch without a pre and post test, without sort of a formal demonstration of accrual of skills, et cetera.
I see. So there's a free version and a $25 version. The $25 version is to meet the mandates of the licensing and be doing telemedicine. Is that right?
Right. And,
okay.
And, I don't know, I mean, you bring up a great point, which I think what you're driving to, which is how do we sort of justify that? If it doesn't become a legislative mandate, then, people could go do the free. And at least it would open up options across the continuum, depending on who's coming to the table and needs it.
Okay. This is great. Questions for Joelle? Yeah.
Do you see any problem with sharing this more broadly, whether it be through the telehealth resource centers or the medical commission, groups like that?
I want it to be available to anyone. I was even thinking we could create a generic YouTube account for people to watch, like even my staff or my team. It doesn't have to be just for the learning and attestation purpose.
Okay.
Yeah.
And this isn't, I'm trying to remember back the content, it's not physician focused, right?
Correct. It's healthcare professional focused.
Okay. So we might be able to look at those entities as well.
Yeah.
Okay.
Anywhere we can get someone to host the video and then I'll point links to that for free would be amazing.
Okay. Is there any reason why you wouldn't want to give them the chargeable version? Send to that, or are we generating any kind of revenue for it?
No, I think this is all breaking even for the Nursing Association. And Joelle and Sarah donated their time for this one.
I did it as a public service.
So you could offer them the ability to get a certificate for $25 or just take it and become more knowledgeable kind of thing.
Right.
Exactly.
Okay, gotcha.
The only thing I would say, Denny, is that it is pretty Washington state focused.
Right.
So if we're looking at, disseminating it across the Providence healthcare system in other states, there's certainly, I would say about 75% of the content is more focused on the general overview of telehealth. And there's some great sound bites there, but we do surf a little bit deeper into Washington state information.
I'm just thinking there aren't a lot of these that I've become aware of. It's a great start and people might kind of take off on this concept, or we might look at it.
No, I agree. I don't think there's any other state that does this.
Yeah.
I think it's first in the United States, but quite a...
Since it is a video, you could edit out the 25%. It becomes like a 15-minute video if you wanted to make a more generic version for outside of Washington State.
Yeah, you're right. It's a PowerPoint. It's a voiceover PowerPoint. So we could easily take out slides.
Yeah, and each slide is recorded with the audio separately. So if we need to rearrange or redo one slide or anything like that, it's really easy for me to do. And for example, I've spoken about this to colleagues in the state of Maryland just because my previous connections and like, we can't wait to see it. We want to do something like this for our state.
Well, and you could refer them to the resource centers for state-specific information, whether it's legal, regulatory, whatever.
Yeah, good point.
Yeah. Jenny, when this comes out, mind letting the NRTRC know about this at least?
Sure.
Yeah.
I'll make a list and maybe run it by you both.
Yeah, I think it'd be great for ATA and the NRTRC.
Good timing.
Yeah, because like you said, that if other states can not have to reinvent the wheel, that's great. And who knows? Sarah might be famous.
Thanks for all your work on that, by the way.
Thank you, Sarah.
Speaking of ATA,
Joelle.
sorry, my proposal to speak about the collaborative and work over the past year was accepted at ATA. So I can make a plug for this training there. And that is Sunday at 3:30 if anyone wants to come and if you're going to be there.
Joella, Dr. Scott, this is Lori. I just had a quick question. So once the provider or healthcare professional completes the training, is the expectation they would maintain a copy of the certificate of completion in their record?
That's right. And then if Washington DOH had any question at the time that they're getting their license renewal, just like you certify that you completed CME, that if they ever audit, you'd have to be able to produce that training. But it's not like they're being proactive. I mean, unless I'm speaking out of turn here, but it seems like this is more akin to what we do with CME.
And we would probably use it in our med staff office to add the privilege.
Yeah, us too.
Yeah, similar to the HIV training that we all needed to do, right? As doctors and nurses in the state, you do it, you get a certificate of attendance, you file it with your CME, just in case you're ever audited, so you can produce it.
Yeah, and similar to, I think, the opioid training and suicide. There's a couple of other things. So, great.
Okay, great.
Other questions for Joelle or Sarah?
So I guess this is probably getting the cart ahead of the horse, but we don't foresee the DOH at some point in time actually coming on site and taking a look at this information.
I don't think so. I think it's going to be at the time of certification if they had any questions. I think the biggest risk is if you have a staff member who has like a med mal case during telehealth, and during discovery they find, oh, you never did the training. I think that would be kind of a knock against them.
And I guess, sorry to get into the weeds here, but if we've got docs that are just doing store and forward stuff, do we probably wouldn't even include that, or what do you think?
A good question. So I just want to make sure everyone heard Chad's question is, what about docs who are just doing store and forward? How many slides were there on that? A couple, right?
Yeah, there are a couple. I guess it depends on the exact language that comes out of the legislative process, right? If they include store and forward as part of the definition of telemedicine, and if you're doing telemedicine, then you need to do the training.
Okay. So it sounds like the safest route is just to make sure that anybody's kind of, in any kind of loosely defined telehealth scenario, they need to be doing this training.
Yeah, and Chad, just a reminder for the larger health systems, that where you might have your own internal training, it doesn't mean you need to do both. But I think it will specify out in the bill kind of the components of what a minimal training is, and the stuff that Joelle and Sarah did met all those minimal requirements.
I'm pretty gung-ho about this, and so I've been talking to the folks over at InTouch and American Well, and I would want their training, I got a little bit of a cold, to kind of mirror some of this as much as possible, because they're tracking a lot of training already, and so I don't want to be replicating a whole bunch of stuff. So that's the other reason why I'm kind of curious about how we're going to.
Well, and
we have the same scenarios too, Denny.
I mean, we used to call like InTouch telehealth training, and it's not really the big picture view, and it doesn't give you the safeguards and the guardrails that you need to practice within. So this is a much better, higher level.
I love this. I just want to make sure that they're also kind of value add when they're making you spend 30 minutes down, that they're kind of complementary as opposed to additional or similar information kind of replicated. So.
That's a good point, and we had to evaluate that as well with our vendor InTouch, because this training will be more global and broad, like what is telehealth, and then the InTouch thing is very technology specific. So then even within our organization, we have some providers using one technology and some using another. So how do you track who has to see what internally?
Yep, exactly. That's exactly where I'm going with this.
Yeah, so I just don't know if folks on the phone or on Zoom heard the conversation, but basically there's a desire to have the technical training, whether it's with American Well or in touch with some other vendors, and have it incorporated with this kind of standardized, more generic, non-technical training. Good. And there's a question from the chat from Dr. Guff. She wanted to know, when is this going to be available? And it's the next month or so, is that right, Sarah?
I think that's what Joelle said.
Joelle, can you confirm when this is going live?
Yeah, sorry. We just got it back to WSNA in the last 3 working days, and so I'm just waiting for the education director to review it, but she said it was a priority. So just judging by, she's already reviewed it, and we returned everything that she requested. I'm suspecting it'll be up in the next 30 days. As soon as it is, I'll notify Dr. Scott, and he can let the collaborative know.
That'd be fantastic. Yeah.
I know they have another priority right now. They have a huge convention that's going live May 1st. So hopefully we're getting in here so they can get it loaded beforehand.
Okay.
Dr. Scott, where do you recommend is the best place to have the video for people who just want to watch it, the free version?
Yeah, I think that probably keep it with all the other collaborative activities at the WSMA, website. I think try to make as much one-stop shopping as possible. That's what I think. What do other people think about the free version?
Makes sense.
Okay.
So just to confirm, the benefit of the LMS is that we really kind of positioned it so that it in fact meets the, is within compliance of what the law would potentially say. So WSNA is not out anything if no one comes to the LMS to take this. So it's really only preparing ourselves in the setting of legislative mandate so that we can fulfill provide an option for people to fulfill the obligations. So Sarah and I also talked about, once we get this all up and running, no matter where the location of this content, how do we want to market it? How do we want to let people know that it's available?
That's a great question. Probably through the professional societies. So WISMA, WISNA, the PT, OT, is there, maybe through DOH?
What would you think about, maybe we could put together a one-pager and shoot it to these organizations and give them the offer of doing either the free version or the certified version. And then I'll make a list of those organizations and people can add to it.
Well, people may be motivated to do the charge version, even if it's not a legislative mandate, because they could get a 1 hour certificate of attendance. WSNA is not, they are accredited with the National Nursing Organization to offer for nursing education hours, but in the moment, they're not going to do that. There's a fair amount of work that goes into that, but it's an option certainly down the road, but they are not accredited with any medical accrediting bodies to do that.
Okay. All right. So Danny is going to make a list of some of the professional societies. We'll send it around, see if we're missing anything. Looks like Leslie Emmerich is saying, the hospice and palliative care organization and home care definitely want to be on that list.
Other people may come to the table if this becomes a legislative mandate and want to put together some education. In the setting of the suicide prevention, at least in the nursing world, the Nursing Commission actually has a list of authorized suicide prevention providers. And I assume if this becomes a mandate, the first thing we should do is reach out to the MQAC and the NQAC, et cetera, and the other folks like the veterinary medicine, chiropractic, et cetera. And they'll probably want to vet the content. And then that will be some marketing in itself because they'll probably post it at their websites.
Okay. All right. Other questions or comments about the training? Okay, thank you very much. Joel, I'd love to write a letter to the folks at WSNA, just thanking them. I think we couldn't have done it without them. And I think it's really shown, the value of collaboration. So maybe offline, I'll get the name of folks I can send the letter. And I think it'd be nice to have some of our legislators co-sign that, because this really is kind of a big deal. We couldn't have done it, the 20 of us. So I do want to acknowledge their amazing support for this program.
Yeah, absolutely. I can get you that contact information.
Okay, fantastic. Well, let's move on to the next agenda item, and it's pretty brief. It's mostly a heads up that on May 21st at 10 a.m., the Healthcare Authority will have a time for public comment, and it's at the Cherry Street Plaza Pear Conference Room in Olympia. And the topic item is to add renal dialysis centers as a valid originating site. I personally don't have any problem with that. I think if you look at Medicare, that's what it's one of the valid originating sites, but there might be others who have a strong opinion, and really just making this available for folks in the collaborative who might be interested in attending that public hearing. All right, so the next thing I want to do is turn it over to Denny, and he's going to tell us a little bit about a report that he filed with the state on the palliative care telemedicine pilot. For the folks in the room, we have a little printed version here, so if you guys did get one. Otherwise, we will send the electronic copy to folks after this, and I'll turn it over to you, Denny.
And please please let me know if you can't hear me, but I just wanted to read you some brief highlights from this report. You might remember, for those of you who were here, Pat Justice from the Department of Health came and spoke to us a little over a year ago about this project as it was getting going. This is known as the Washington Rural Palliative Care Initiative, and we also have the Rural Healthcare Integration Advisory Team that's part of that. And this is 24 public and private organizations and palliative care telemedicine expertise that Pat leads. And we've had some pretty amazing success in the first year. It's also a multi-state project that's led by Stratus Health, the health improvement organization out of Minnesota. And the goal of this is really to assist rural health systems and communities in integrating palliative care into multiple settings to better serve patients, particularly in rural communities, move upstream to serve patients with serious illness earlier in their illness, and then to develop funding models for sustainable services. So what we did initially was we put together a coalition of 6 or 7 rural hospitals, our initial cohort, and we engaged in community engagement with them and educated them on what palliative care is versus, let's say, hospice care. And we worked on education, clinical and cultural change strategies, and then we initiated telehealth case consultations and clinical telemedicine. So the goal is to improve symptom control, improve the patient experience for family, and improve quality of life, and ultimately to decrease emergency department visits and readmissions. So during the first year, we held bi-monthly interactive case conferences, much like a Project Echo type of case conference. And we had palliative care providers, social workers, palliative care pharmacist experts, pastoral care, so a number of different groups, and they were amazing to watch because they're very, very, very complex cases. And so to hear some of the things that these groups and hospitals are trying to deal with is heart-wrenching, but it's amazing when you get a group of experts that do this all the time, what they can help the rural practitioners learn from the experience and know where to go for help, but you ultimately educate them and help them get better. So we did those bi-monthly, and they turned out very successfully. We're going to be turning those into some additional educational opportunities and webinars. And then the goal for this year is to work up towards telemedicine consultations out in the region. And it's been getting pretty good word of mouth, and so we've had a lot of other health systems and health organizations asked to join this. So we're looking at some additional funding opportunities as well. And there was a group from several of the hospitals that approached the long-term care Committee on Aging and Disability at the legislature from Dayton and Pullman and asked for additional funding because they recognize the value of this program. And it was also interesting to note that one of our pilot sites was Dayton, Washington, showed a 68% reduction in emergency department visits for the patients that were going through this program. So that's ultimately the
68%.
68%.
Wow.
Pretty solid data to support. So Pat's done a wonderful job at leading this effort, and we're excited to see it grow.
So Danny, next steps for this program?
The next steps are we're obviously going to continue to look for some more funding because we'd like to allow those additional organizations to join and participate. But there's a fairly significant cost to putting all this together. And as we move to telemedicine consultations, we're going to need to figure out things like care coordination. You know, that's a pivotal role in how you work with the resources you have and coordinate the patients that need that service.
Did you say funding, is it a one-time investment to set things up, or is this more like financing services moving forward? The reason why I ask is that Cambia has a palliative care foundation.
Okay.
And so I'd like to learn more about how we can get these two groups together.
Sure.
They do have funding, but they also, more importantly, care a lot about this topic. And so I think it'd be good to connect. And I've had conversations with the I guess the president of the foundation, and telehealth is something that they're really interested in bringing. So it seems like there's just a lot of synergies.
Okay.
So
I'll connect you with Pat, and she can probably articulate this best as far as how that would be helpful.
Okay.
Danny, what were some of the challenges that you faced?
I'd say the heaviest lift on this is we worked with one of the CNOs that came from Stevens County, and she's down at Pullman. And she pulls all the complex cases and evaluates those and kind of preps them for a case discussion, and then works with the rural hospital that's going to present those, making sure we have the right people at the table that involved in the team and that can address that particular symptom or set of symptoms. So they're pretty complex case coordination kinds of things, yeah.
So it's kind of the back end case management.
Logistics.
Yeah, just getting all that data.
Exactly.
Herding cats.
But I have to say it was just tremendous to sit there and watch and listen to this. I learned a lot.
That's great. I'm wondering if we can get comments from Leslie Emmerich. Leslie, I know that you represent the Washington State Palliative Care Association. Were you a member of this pilot, or
Trying to unmute her.
And hold on, we're just trying to unmute you, Leslie.
Yeah, our members are really excited about this. There's a lot of people that are involved in the training. As you know, Dr. Greg Vandekeef's been very involved in this. We're very excited about the pilot. I think that there's a lot of opportunities coming up for telehealth, not only in palliative care, but we've got to build this legislative session, Senate Bill 5828 regarding Medicaid home health. It has a telemedicine component as well. So, yeah, we're very excited about this. And thanks, Denny, for all the great work that he's done on this.
And thank you for your advocacy. She's gotten it out there in front of a lot of people and made it known, so that's good.
When does the grant wind down, Denny?
I can't answer that question, but I will find out.
Yeah, it'd be a shame to not be able to continue this. Denny, are there folks in the legislature who might be interested in hearing this. Obviously, Senator Cleveland and Senator Becker might
Yes.
want to know about this.
I will direct this report to the folks on maybe healthcare and long-term care.
Yeah.
Okay.
I think they would be interested, especially 68% reduction in ER visits from one hospital.
Significant.
That start to add that up. It's not just the cost, but the inconvenience of, for the patients. It makes a big difference. Okay. Well, thank you, Denny. That's really exciting, and congratulations on that work. Okay, so the last item is to review our charter and the goals that we outlined, and then to discuss where we'd like to go in the next year. So let me pull that up while our review back here. And I'll share my screen. All right, let me blow this up. Just remind folks what we talked about 2 years ago. We were trying to do. So for folks who are on the phone, I'm just going to read it. It's not that long. So the vision statement said, the collaborative will advance excellence and innovation in telehealth for all Washington communities, improving access to high quality, safe, and affordable healthcare in Washington State. And our mission statement was to provide a forum to improve the health of Washington residents through the collaboration and sharing of knowledge and health resources statewide, and increasing public awareness of telehealth as a delivery mechanism. Collaborative seeks to enable development and delivery of technology-assisted programs that promote access, sustainability, utilization, and affordability of telehealth services. So we had, looks like 6 goals. The first being to improve the access to telehealth education and resources for both patients and providers. Number 2, to enhance the adoption of evidence-based telehealth through a positive patient and provider experience in reliable technology with interoperability. Number 3, to develop recommendations on improving reimbursement and access to services, including origination site restrictions, provider-to-provider consultation models, and technologies and models of care not currently reimbursed. Number 4, identify the existence of guidelines, clinical documentation and billing requirements, liability and fraud prevention developed by recognized medical and telemedicine organizations. And number 6, to make recommendations regarding development of a privacy and technical assistance center to provide implementation and expanding services. So let's take a look at that and see if there's maybe some gaps in what we've talked about in the last 2.5 years, and if there are things we need to dive into in the next couple of meetings that we're getting together.
Not sure if this is it's outside of this list of goals. I'm not sure if it's outside of the desire of this group, but I brought up a couple times about just consumer perceptions and consumer adoption. So we're focusing a lot on the mechanics of payment and quality and foundation, which is all very important. But as far as the other side of the coin for utilization to really increase, there's the consumer aspect of it, and what do they see as some of the experience challenges? Like just anecdotally, when we do our focus groups, there still seems to be some perception that in-person touch feel is superior to virtual, and definitely being part of this collaborative and just being in a space like for certain things clearly, but I think in many cases that care is equal, and so it's not really to convince me. So I'm not asking this from my perspective, more from the consumer adoption perspective, how do we get patients to really embrace this, understand, when they should be really considering these types of services and even, request it, as opposed to not knowing about it.
Okay. So going back, let's make that first goal is improve telehealth education to patients. So let's break that down a little bit more, Brody. Do you think as a starting point it'd be good to talk about some of the focus group issues that came up, or look at the literature? Would that be, or how do we get into
put
that?
as much thought into how. I think it's just we just haven't really talked much about things from a consumer patient perspective. So at this point, it's just an observation. But yeah, definitely, I think the question is, what do we do about that? Because I think looking at focus group, that might be interesting, but what is ultimately the goal after that, right? Just to get a better understanding, I don't think is the ultimate goal.
That's a really good point. I'm wondering if we thought about forming a subgroup that could focus on that, maybe develop some strategies around ways to educate the public.
Yeah. Are there other people who are interested in part of the subgroup?
Actually, yeah. So we have patient family partners at Virginia Mason. And we've been trying to involve them in all of our direct-to-patient or direct-to-consumer service lines as we're building them out. And it's been huge because you're aware of the knowledge gap, but you don't really realize it until you actually get a patient in there saying, I don't feel comfortable. Tell me what's going on here. And then there's all the early adopters that are 10, 15 minutes, because it's been a real eye-opener as we've kind of gone down this road as to how important it is. And we're trying to create some ancillary videos and stuff like that and put them up on our website so people can actually kind of interact with it and stuff. So yeah, it's good. I think I wanted to tag on to that too. I think, forgive me for going back to nursing, but the devil's in the details when it comes to consumers. And so, are we doing our part to put forth any research projects, or I haven't been here long, and so I don't know how long this group, or if they've ever endeavored to take on any kind of research projects that would support the safety and efficacy of telehealth as a care delivery model. And so sometimes people or the public wants to latch onto that. Is this science driven? So
yeah, it really gets into maybe that second point about evidence-based.
Yeah.
It's all over the place. Like someone who reads the literature, and it's hard when it's so much all over the place. So
it'd be cool if we could take something like this palliative care report that's more of a large group effort, and it's not Providence or UW's focus on it, and shows how we're educating providers to work with other types of providers, but ultimately to help the patient, and then it's moving towards telemedicine. Kind of figure out how to pull that all into telemedicine, but educate people on kinds of things we're doing.
Not only that, we have such a wealth of resources in this group. That's such an amazing project. Kudos to you guys for taking that on. How do we make that a pilot project and something that we can spread across all of the organizations so that we're offering this to a whole bunch of folks,
Yeah.
So things like that are very cool, and we would be committed to helping in whatever way we can.
That's great. I know that the UW would be very interested in research. That's something that we are known for, and I've done a little bit of research. It's hard. I'll tell you,
It is hard.
It's hard to get patient-level data because you're working with so many different electronic medical records and all the different securities and things like that. But we do have one ace in the hole, and that's the all patient,
all claims payer,
all claims
Payer claims database.
the all payer claims database, which we heard about last May. So as we see more and more people using telemedicine, it'll probably get flagged in there. We can kind of start to see, what's the payment for this, and there might be ways to look at subsequent care of those people.
Yeah, the database is
being shifted. My understanding is OHSU will no longer be sort of the backbone of that database, and so the legislature is right now figuring out who will be the owner. And I can't remember if it's going to be HCA or OFM, but it'll be one of those two. I'd need to look at the bill. So, but I certainly think that's a question that you could ask them.
You want to introduce yourself?
Oh, yes, I didn't do that at the top. Marissa Ingalls with Coordinated Care, previously helped out on some UW Medicine things, so I still show up and thoroughly enjoy the work that this group is doing.
Thanks, Marissa.
Yeah.
Great. I wonder if we could go back to Danny's suggestion of a subcommittee focused on the patient experience. Sounds like Danny and Chad and potentially Brody be interested. Is there anyone else who might be interested in working with them?
This is Lori. I would be interested from Legacy.
Okay, Lori Wakashigi. Thank you, Lori.
And this is Francis Goff. I would love to be involved.
Thank you. Just kind of expanding on your idea, Chad, what do you guys think about actually bringing patients to this group? And, you know, maybe we could have one or two and just say, we want to hear about your experience. What was the good, bad, and the ugly? We've never done that before, but I think that might be really helpful to hear.
I would be happy to be a surrogate to tap into some of our patient family partners. I would certainly want to open it up to you guys also doing that, but absolutely. I found it to be just incredibly insightful and very helpful as we start to build out our kind of internally focused programs. So yeah, huge.
Okay, maybe I can ask some of the folks who are on the provider side. So Danny, Kathleen, Sarah, myself, obviously, Carl Towell, Stephanie at Multicare. Maybe if you guys could think about one or two patients, and we don't want to hear all the rosy stuff necessarily. Obviously, we don't want to also hear the super negative stuff that might be not appropriate. But it'd be good. I think it'd be really good to see if we can get patients to join us.
And we can offer, so we have access to be able to turn around like large quantitative studies pretty quickly. And so if there's certain types of, like we could say, hey, give us 1,000 people that have had a telehealth visit within the last 3 months. And if this group has a set of questions you want to ask about their experience, we could turn that around in like a week.
So like a survey, you're thinking, Brody?
Yeah, so it's a survey. We can come back with the stats as far as, there's even free form text responses. If you say, you know, what are your barriers for this, we could, I mean, that would take more than a week to kind of organize free form text, but to the extent that there's just survey percentages that we want to pool as far as what proportion, and we can take a cut of, you know, any part of that population, but we could offer pulling that together. We use those survey tools all the time.
Yeah, that would be really great. Maybe that's one of the first tasks of the subcommittee is to think of a survey.
Quick slices to at least where we stand today.
Yeah, thank you. That'd be a real great resource, I think, for the group here.
In thinking about research, and Chad, your points in the All Payers Claims database, what we're running into a lot is how do we prove the clinical outcomes of telehealth are equal to or better than in-person care, right? So a lot of the metrics we've just thrown out in discussion today are very administrative and process oriented. So how do we start to capture that as a collaborative? What advice do we give provider organizations to, you know, think about this as you're setting up your telehealth program so you can start to capture these clinical measures?
I think that's spot on. I remember last fall when we were in Washington, D.C. visiting legislators' offices and talking about telehealth and reimbursement specifically. They said it's all about the data. I have to have significant, meaningful data to go to CMS, and that the OMB is going to not throw out because it's not relevant, to be able to convince them that they need to think about funding additional CPG codes or whatever. So I don't think many of us have a really good handle on what meaningful data is to CMS or OMB. And that's where we really need to start.
Denny, did they have a handle on what that is either, though? I guess my question, I mean, it's kind of paradoxical, right? Because I bet most of us would be willing to collect information or take part in that. We just don't, what do they need to see, I guess? And you're right, outcomes is going to drive a lot of this. But,
and it's unfortunate because a lot of us look at ED avoidance or readmissions, and they don't necessarily count that in the same way that they do cost savings or not a cost increase to adding something in CMS telehealth.
Yeah, it's really hard to prove savings.
It is.
You have to it gets into pretty complicated statistics. And you always have the reversion to the mean. Similar to your suggestion about having a subcommittee on patient engagement and patient perspective, I'm wondering if it'd be a good idea to have a committee on research and to try to think about it. And I'd be really interested in that, I know. Sarah?
Yeah, me too. And I can reach out to my colleagues at the Benaroya Research Institute and see if this is something they might be interested in participating in as well. So,
okay. Great. Fantastic. All right, so it sounds like trying to get a little bit more information on the patient perspective, their barriers, their viewpoint. We're trying to do a little more research, especially to prove or disprove the value of telehealth for our patients. Let me pull up the goals again, see if there's stuff we can dive into. What about this? What about some of these technical issues, like interoperability? Is that something that we need to talk about? Has that been a problem for folks?
I take it as not just EMRs, but as telemedicine interoperability. Yeah.
And that gets in, if there's interoperability issues, then that argues more for a technical assistance center. I have to say my biggest issue with interoperability is making it work with our EMR. And we're Epic, like a lot of, you're not Epic, are you?
No, we're Cerner.
Cerner, okay. That's a whole different ball of wax. So I can imagine electronic medical record.
Well, a stretch from that, I know this wasn't the core of the question, but some things that are coming across my desk more regularly now is the use of devices that augment the telehealth visit. So whether it's a virtual stethoscope, whether it is, even digital thermometers, as basic as that is, like, how accurate is that information? Is there certain guidelines on how to utilize those things? Is more information better than no information, but you don't really know what device they're using and they're just giving you numbers? There's a whole bunch of remote monitoring types of things in place right now. I mean, it's definitely here, but I don't know, it seems like the next step of the maturation process beyond just being able to see something through video, but now adding all these other peripherals. Is this a space that this collaborative wants to be in? I know it's not the core to interoperability, but it's still, the devices make it even more confusing.
I mean, I think it is, because we do talk about new technologies and models of care that are not currently reimbursed, and folks may know that remote monitoring is now being paid for by Medicare.
Covered as well. So
okay, it might be good to come back to it, and we can approach it from a variety of ways. We can look at some of the technical challenges and how do you even vet reliable technology. You're saying.
I'm not sure if folks are aware that there is one national telehealth resource center. It's called the Telehealth Technical Assistance Center. It's based out of Anchorage, and that's what they do. And so that's a great resource to have, and it's free. Stethoscope comparisons was a good example of one of the things that they did recently.
Technical
Assistance Center, TTAC. If you go to the National Telehealth Resource Center website, you'll find all the resource centers, and there's two of them: the Center for Telehealth and policy, not CTEL, pardon me, Center for Connected Health Policy, which is a great one for reimbursement and legal, and then the technical one. And then there's the individual state ones.
Denny, do you know if they ever do road shows? They ever, if we invited them to come down to Seattle, it's probably the shortest flight they could do.
I can ask.
Yeah. And because I think that would be really helpful to have just a demo, and they can walk us through some of these things.
Talk to Deb LaMarche upstairs. And
yeah.
Okay.
And maybe it's a combined thing with the NRTRC. A TTAC could make a field trip. But I think that's a great idea, is to learn a little bit more about it, with some of the challenges. Take a deeper dive on that.
Hey, John, this is Joelle.
Yes.
Can we go back to the goals for a second? I had some thoughts. So first off, do we run any analytics on the website to understand what kind of traffic we get? Do we know what our reach is?
No, I think you can through like Google Analytics. You can see, how many hits you're getting, where those people are. But that's a great idea, doing analytics on the website.
Well, I'm just thinking, kind of backing up here, who is our target audience? What kind of impact are we looking for? Kind of thinking through some of the things that we have done. Really, it seems like the first 12 to 18 months was just kind of getting established, sort of start up on the website and kind of laying some foundation. I think that we need to consider the fact that we're all very busy, but how can we turn out, a couple of products a year out of this collaborative that can be valuable without duplication and resources that people can find elsewhere? And I think some of our goals overlap with, for example, the last bulleted goal, make recommendations regarding development of a privacy and technical assistance center. I don't know that we really need that there anymore. I think that that's established nationally, and like Denny was just pointing out, we've got a resource center that really leads this country in technical assistance, support, knowledge, information, up-to-date information on technology that's out there. But how do we hone it a little bit to be more specific to Washington State and impact what's happening here, but also create a reach so that people know about us? And I don't know, I think we do really great things. We're learning a lot as a collaborative, and we have a volume of expertise at the table here. And probably we represent the biggest, most concentrated resource to Washington State, anybody who's interested in telehealth. And yet I don't know that we're sort of the legislative bills that are in motion now. I don't know that we have a lot to show for for the time that we've spent together. And we all know that it's difficult to do things, but I think we could break off into subcommittees or subgroups and tackle, projects so that we have something to offer Washington State. And maybe that means that we start really kind of focusing on measurable outcomes, measurable goals that are realistic, that can be published at our website so people have resources.
It's a great idea. Just to summarize what you're saying, trying to have more concrete, SMART goals, right? And getting down more into brass tacks. Joelle, do you want to say a little bit more about maybe some ideas you have around what would be some metrics that you think are meaningful?
Well, just kind of thinking through this, number one, I think that it would be valuable to perform a gap analysis. What is out there? And I thought about this as we went through, as Sarah and I worked on this slide deck, and I got a little more knowledgeable because obviously a number of collaborative members worked on this slide deck. But thinking through what's out there and what's not out there and what's specific to our state. And this is where I think the need is how do we create something that is very specific to our state so that people don't have to go out and kind of surf through resources everywhere to figure out what they need to know to practice in our state. And so, although I don't intend to be exclusive to Washington State, this is a Washington State legislature. We're supported by the legislature, and I think that is one of the highest impact resources we could provide if we view ourselves as an entity that should be providing resources to whoever our target audience is. So that would be my first approach is let's perform a gap analysis. Let's figure out what's out there and what's not, and how we could provide some resources that are very specific to folks in Washington State who are practicing here. I'm sorry.
No, go ahead.
And something that people can actually, it's wonderful that we exist, but I don't know that there's anything that we're doing currently short of our slide deck that's going to go live and our legislative bills that are traveling right along and hopefully will pass, that will really move Washington State in a great way. But we also need to advertise that. We need people to know that that's happening. And I think that we have potential strategic partnerships that we're not tapping into. So we have a lot of, super partners at the table here, but how are we disseminating and going back to our organizations to share what we're doing here? And I think that really kind of, lies upon us. The other thing, I think an area that we could really work on is kind of thinking of telehealth as sort of full circle. And so many of us are out, our clinicians or leaders who are facilitating clinical dissemination or implementation of telehealth. But how do we develop providers? How do we get people to the table? How do we continue to create knowledge in our community? But is there anything that we could do to really create a greater buzz and confidence for people to come to the table? I think that telehealth continues to struggle because providers just don't know how to do it. Leaders don't know, there's not always a lot of buy-in. And so we're kind of in this world and we have this concentration of people at the table who are, up to their elbows in this work. But truth is, what is the uptake across the state and how do we get more people to the table? And I think that does that mean that we approach Cambria Grove and ask them to do, maybe we have a panel where we get more reach in the community? I feel like we're very insulated and very, we're kind of in a silo, and we could do other things that wouldn't have to be a really big commitment if we all pulled together, but we could do some cool things in the community to continue to disseminate, but also get some face value out there.
Yeah. So a gap analysis, trying to reach out to some of our partners, whether that's the Northwest or the Primary Care Association, meeting next door.
Mm-hmm. And maybe we hold a CME, maybe we approach Virginia Mason or Swedish and say, they all have education departments and say, hey, will you host an 8-hour CME? I mean, with all the resources that we have right here on this collaborative, we could all give talks and that would be so easy and so much fun and give us a lot of, it would just, it would create some awareness that we exist, but I think we would also be providing a service to our community members across the state.
It really sounds like it's kind of developing an advocacy strategy. We started talking about it with patients, now it's other entities and organizations, but we're contributing the content. So I just wonder if maybe we should think about it that way.
Right. I mean, that sounds like another group. Got research, got patient experience, advocacy, education. Okay.
I will add, we just did a CME event.
Yeah.
It was neurosciences, but we had a telehealth speaker from Thomas Jefferson come out. And actually, it was extremely well received. It was one of the favorite talks of the entire CME. So people were very interested in what they had to say.
They do a good job.
Yeah, Tom, Jeff, yeah, those guys are they're awesome.
What are other ideas that folks have for like how this can be useful to your organization and also just the patients around Washington State? Maybe Stephanie or Francis, Chris Cable. You guys had a chance to chat.
This is Francis. Can you hear me?
Yeah, go ahead, Francis.
Well, I know that anyway, first of all, back to an earlier part of the conversation, that we could identify a way in which to best communicate to subpopulations. I know that it's likely different, the communication modality that's going to be most successful to engagement, because engagement is the key to, adoption and then, getting the word out and having higher utilization of these programs. But it seems like it's the biggest hurdle. And to be able to study that, especially across commercial or Medicaid, for example, populations, would be incredibly useful to drive adoption. So I just wanted to underscore that part of it first, because I don't think we can get very far without that. Sure. And then most certainly the metrics are critical. And I know, I'm running from one place to another, so I catch my brother. So when we talked earlier about different use case scenarios, I was hoping we could maybe touch on that. I know palliative care is one. There's potentially some of the others we talked about. Opioid telestroke. It doesn't have to be those necessarily, but to be able to take something that's fairly well defined and build a use case from end to end, looking at how do you engage people, what kind of people, what are the challenges, what are the barriers, what's been successful, what's not been successful, all the way through to the metrics at the end as how do you define a successful program. And then have some of these as proxies, as templates. It seems like I totally agree that we really have to have the data at the end of the day to prove the value of all of these things we've spoken about. And it's kind of a culmination of the charter, really, in my mind. So I would just like to want to put that out there as just another thought, I think, from my perspective. And we have a lot of providers wanting now to do these programs, and it seems like the perfect opportunity to be able to, get the community together around piloting some of this to make it worthwhile and to prove the value across, multiple different areas. So that would be my comment.
Okay. So Francis, do you think it'd be like a really common condition, either like mental health or diabetes, that we'd want to tackle, or?
Well, certainly, I think a very meaningful condition. Obviously, there's so many, but I think there would need to be some type of a program, though, that is relatively easily and quickly available to stand up. And I think a subgroup committee that kind of fleshes that out, looks at the components and what the process metrics are, what the the outcome metrics are. I think that it would be really a really deep dive use case scenario would be very important. And, I'd be open to any number of things that we could start to look at, but something really meaningful and relevant, to the population. And also, it's also maybe something that, maybe some of our, rural providers are struggling with, becomes even more relevant.
Okay. Do you think talking like DOH or Medicaid would be helpful to kind of see if there are particular conditions are really hard, and they think that telehealth would be, a good use case?
Sure, I think so, and I think this could be anything from, some of the disease, from chronic disease, sort of a population health approach. It could also be something like, immunizations, or it could be, some of the, preventive care measures as well. It could be any number of things, but I think that might be good to engage them, you know, and have their support. Absolutely.
Okay. The other research group that's taking a population health perspective is the UW Institute for Health Metrics and Evaluation, IHME, which has like county level statistics. So they can say, Kittitas County, these are the top 5 causes of death. And they can, you know, the nice thing about that is if you make an intervention, you can kind of see how it's changing population health. So that's another resource that could be engaged. Chris Cable, did you have a comment?
Yeah, I think I might have been on mute before. Can you hear me now?
Yeah, go ahead.
Yes.
Thank you. So yeah, just a couple ideas as I look at the goal statement there, and I do like everything which is brought up already. I think the parts I would add are, you know, my worry with telehealth is always that it's a double-edged sword around increasing adoption and utilization, and I know we have the position there around using an evidence basis, but I wonder if we want to add something about value add or minimizing low value utilization, because I think we all know sometimes things can be evidence based and yet still end up to be low value, especially if they're duplicative. Someone has telehealth and for whatever reason they couldn't accomplish the job and there's face-to-face visit anyway. We see that happening at KP with some regularity. So just to think about trying to balance that drive for adoption, but making sure it's appropriate, that it's got value. I don't know the exact wording per se in the goals, but I think it would be reasonable for us to include that as our future state that we want to drive towards. That's one thing.
Okay.
The second part around the reimbursement, I see there's a reference in the goals to improving reimbursement. I think that was totally the right word when we started because reimbursement was basically zero. But now that we're getting to a state where we're talking about things like parity, I don't know if ongoing use of the word improving over time in a durable charter starts to feel a bit like advocacy. And I wonder if we want to talk about equitable reimbursement or reasonable reimbursement or some other word besides improving, just thinking about the long term.
Okay.
To add to that, I was thinking it should be more centered around payment models and not necessarily reimbursement as we move to more value-based payment models.
Yeah, I like that.
Cheryl, Uchala, or Stephanie, do you guys have any comments on our goals?
This is Cheryl. I don't have anything to add other than what's been talked about already. I like the idea of advocating this and understanding more why members may or may not want to use telehealth.
Okay. Lori Wakashigi, anything you wanted to add?
No, I think the subcommittees that are breaking out but are forming for advocacy, as well as the patient, what was it called, perspective group, I think those are really good. Something that I actually had a question about, though, is where do organizations come together with payers to have discussions about how to create models of reimbursement that are going to be understood by everyone? Because I think a lot of times what happens that I've seen so far is that organizations will define billing codes, and then once we start reimbursing or trying to attempt to reimburse for some of the things that we're doing, a lot of the payers don't recognize that and won't reimburse. So I'm not sure where that can come in some of this work.
Okay. So payment models, what Sarah and Lori were saying.
Payment models, especially as new services like home monitoring are coming on board and video visits are expanding. Okay.
Okay. Great.
And pending some of the final language, if the bills, the payment parity bill gets passed, there was something about directing us to study store and forward reimbursement and things like that. So that would fall under a payment model subgroup too.
Yep. Leslie, I know you have to run. Did you want to say something? Leslie Emmerich?
Yeah, if I could just briefly. It's really interesting to me. You know, in-home services, home health, hospice, and home care, that includes palliative care, is just such a natural environment for telemedicine to be happening. And I'm wondering if even it makes sense to have a group working on that. But that bill I was talking about earlier, Senate Bill 5828, that's about Medicaid home health, matching the reimbursement rates to Medicare and reimbursing for telemedicine. And there's going to be a work group that's held over the summer, and even if it gets funded or not funded, it passed the Senate unanimously. I'm waiting to see what happens in the House. It may just be the work group. And I've already been contacted by Gail Krieger at the Healthcare Authority and Marianne Lindebat, and they want to start talking about how we can provide telemedicine for home health. And I think there's a really big piece there that kind of relates to that palliative care, that 68% reduction in readmissions. And we've got some of our providers who have a special contract with Kaiser Permanente that are doing a telemedicine type monitoring in between the days that the nurses are there, and their readmission rates have dropped significantly too. So trying to figure out what the best technology for that would be, how it would be reimbursed, all of that is going to be what the work group's going to be working on this summer. And I'm going to be inviting Denny Lorden to join us this summer on that, and Pat Justice will be part of it as well. But I can see kind of a connection here with, you know, the telemedicine collaborative as well. So just want to put that marker in there for you for the future.
Okay. Right. Do you think it's appropriate, guys, to maybe redo our goals from this? I mean, I think both Chris and Brody seem to be alluding to, like, yeah, this was great when we started 2.5 years ago, but maybe it's time to let's look at them again and maybe actually try to get a little bit more measurable outcomes on these things. So what do people think about trying to next time talk about new goals?
Maybe in the meantime, we could all send in goals, and we could collate them before the next visit and then revise them.
Yep. Great idea. Thank you, Joel.
It's just a round robin.
Make my life a lot easier. Yes, I agree. I think we've got some good starts here, but we'll ask people to send those in. We can take a look at them, and I think ask for the goals to be measurable, and that they could be linked with metrics that, like Joel was making that point. Okay. Anyone else want to chime in about goals and where we want to take the collaborative the next year or so? I think that's a good start. Be really helpful. So, and I'll ask other half our group today. Chris, did you want to make a comment?
No, I think
okay.
Your proposal is great to readdress the goals.
Okay. Good. That's all I had for the agenda today. I wanted to open it up to public comment at this time. If there's anyone who is on the call and would like to comment on anything that we talked about or we didn't talk about.
I do have something I'd like to chime in on based on your previous conversation, but I'll defer to anyone who's on Zoom first if they want to do that.
Why don't you come sit at the table so we can
yeah, sure. So again, Marissa Ingalls, Coordinated Care. I really appreciate your comment about looking at other payment models as a part of the various subgroups that you all sort of decided to tackle. One thing that Medicaid groups, the MCOs, are struggling with in Olympia right now is a very heavy focus on fee-for-service. And that seems to be what the legislature, or legislators rather, understand the easiest, as sort of a simple understanding of healthcare, right? And we all know that it's much more complex with that. And MCOs are under a lot of focus from HCA, I'll say, to transition to more value-based payment arrangements. That is something that HCA is putting a lot of attention to. It's also part of the Medicaid waiver work that's happening with the Accountable Communities of Health right now. So personally, I would love to see this group sort of align with some of those efforts to look at where other conversations are going around payment models, and especially how we do that for telemedicine. So that's my other hat that I wear doing ACH work. We're partway through integrated managed care rollout, where a lot of those arrangements are being put into place with the provider networks from the insurance side. So thank you for bringing that up. Just want to reiterate that. I have a brief legislative update for you on the training bill that is currently sitting in the House Rules Committee. So I think that you should all expect it to be passed. I'd be very surprised if they didn't. It is not a controversial bill at all. And it does refer back to the telemedicine definition RCW. So I believe that includes the storm forward.
Oh, great, thank you.
Yeah.
Great, thanks, Marissa. Anyone else want to comment at this time? Anyone from the phone or Zoom? Okay, great. So I just wanted to wrap up with announcements for our next meetings, just to remind you that we will be making our first foray into Vancouver on May 6th at 1 p.m. We'll be hosted by Lori Wakashi at Legacy. And Lori, just so you know, we brought all of our equipment today here, and all we needed was Wi-Fi, and it seemed to be working out pretty well. So if that makes you feel a little more comfortable in hosting us, we have a lot of the equipment and can get down there. And then June 27th, we'll be in Confluence in Wenatchee. So any last comments? I think there was one person who still wanted to say hi. No? Just heard someone breathing. Okay. Well, great. Thanks, everyone. We will see you in May.
Thank you.
Thank you.
Thank you.
Thank you.